Okay, chapter 19, we're talking about heart failure and dysrhythmias. So, in this chapter, we'll talk about heart failure, pulmonary edema, which is something that we can see with heart failure, and then heart failure treatments. So, what is heart failure? Well, we first have to think about what the heart's role is in the body. So, the job of the heart is to relax and fill up with blood, and then to contract and eject blood. We want that blood to perfuse throughout our body's tissue because it's delivering good things like oxygen and nutrients, as well as taking away waste. In order for our heart to do this job correctly, it has to be able to move, it has to be able to contract, it has to be able to fill up with blood. We have to have enough blood in the system to be able to transport throughout the body. Now, heart failure is the impaired ability of the heart to pump blood to maintain sufficient cardiac output to meet the metabolic demands of our tissues and organs. So essentially, our heart would still be considered as failing, even if it's pumping out blood, if it's not meeting our body's needs. It will result in things like congestion of blood flow in the systemic or pulmonary circulation, depending on which side of the heart fails. Sometimes it'll just be the right side failing or the left side failing. Incidence increases with age, and the most common reason, and this is the most common reason for hospitalization for those over the age of 65. Now, what's the etiology and pathogenesis of heart failure? So it's a potential consequence of a lot of different cardiac disorders. So myocardial ischemia is one of the most common causes. Also, you can have an acute myocardial infarction or a heart attack. Hypertension, so high blood pressure, can lead to heart failure because you're really working the heart. We can also have just degenerative conditions, which we collectively call cardiomyopathies, or maybe it's an excessive work demand on the heart. We're in a hypermetabolic state and we're causing our heart to work harder, and eventually it just peters out. It could also be due to a volume overload. If there's too much blood volume the heart has to work against or to move, then that can lead to heart failure. And renal failure could lead to this volume overload. And heart failure results again from the impaired ability of our heart muscles, our myocardial fibers, to contract, to relax, or both. Because again, the job of the heart is to relax and fill up with blood, and then contract and eject blood. Now, there are different types of heart failure. Mostly when we think of heart failure, we think of the low output failure. This is where the heart is not pumping out enough blood due to ischemic heart disease or cardiomyopathies. But we can also have high output failure. So in this instance, our heart is actually pumping out a lot of blood. We have supranormal output, greater than normal output. But we still have heart failure because remember, heart failure occurs when our heart is not able to meet the metabolic needs of our body. And so even though we have a lot of blood pumping out, it's still inadequate, maybe due to excessive metabolic needs, or maybe because we're anemic. And even though our heart is pumping out a lot of blood, there isn't a lot of oxygen in that blood. There isn't a lot of red blood. There aren't a lot of red blood cells carrying oxygen in the blood, so it's still not meeting our body's needs. Or maybe we have a shunt, and so the body is not actually getting adequate blood supply. Then we have systolic and diastolic failure. So the failure is limited to the heart during systole. That would be systolic failure, so impaired ejection of blood from the heart due to things like decreased contractility. It can't contract, or maybe there's volume overload or pressure overload that it can't overcome. Or we have diastolic failure, so failure during diastole. So there's impaired filling of the heart due to maybe smaller ventricle chamber size. So hypertrophy of the left ventricle can lead to that, or poor compliance. The heart can't relax and stretch to fill up with blood. And then we can have heart failure limited to each hemisphere or each side of the heart. So right-sided heart failure or left-sided heart failure. So in right-sided heart failure, we have impaired ability to move the deoxygenated blood from the systemic circuit to the pulmonary circuit. So we really can't get the blood to the lungs adequately, and we also aren't receiving blood well from the body. In left-sided heart failure, we have impaired pumping of blood out to the body, and we're not receiving the blood from the pulmonary circuit. So we have a buildup of blood in our lungs. Now let's take a look at our ability to adapt to low cardiac output. So in heart failure, typically, again, there's going to be low cardiac output or low output to meet the demands of the body. So our body will try to compensate. And so again, it's an emergency, so we will activate our sympathetic nervous system. The sympathetic nervous system can increase our heart rate and increase contractility. Both of these together will increase cardiac output, since cardiac output is heart rate times stroke volume. In addition, we can turn on our RAA. And when we turn on the RAA, we retain more fluids. And when we retain more fluids, we increase blood volume. And when we have more blood volume, we have more blood returning to the heart. And this really calls on the Frank-Starling mechanism. So this is related to sarcomere length. And if you recall from your normal physiology, our heart muscles have sarcomeres. Our heart muscle sarcomeres at rest are typically shorter. They function at a shorter sarcomere length than optimal length. And so what that means is when we have more blood coming back to the heart, our heart muscles will stretch. And as our heart muscles stretch, our sarcomeres stretch. And they actually stretch to a more optimal sarcomere length to produce greater force. And so when we actually have more blood returning back to the heart, our heart muscles will automatically contract with more force just because of what we are doing to our sarcomeres. We are stretching them. And so this will increase our cardiac output because that will increase the contractility of the heart, how forcefully our heart contracts. And then we have myocardial hypertrophy or remodeling of the muscle. So the heart muscle, because of this increased demand, will actually begin to hypertrophy and increase in protein to try to meet the demands of the body. So different ways we can compensate. And we also see increased vascular tone, and that will also help with blood flow throughout the body. Okay, so here's that Frank-Starling curve. So in the Frank-Starling curve, we have our optimal sarcomere length shown here. And this is with the dotted line is with normal heart muscles. And then here is with heart failure. But what you can see is in optimal sarcomere length, we have good overlap between the thin and the thick filaments, but we still have room for the filaments to slide past each other. And so you'll produce the most amount of force. In the heart, our sarcomeres function actually shorter than optimal. And by functioning shorter than optimal, what that means is the greater the amount of blood that comes back to the heart, the greater the preload. Preload really is the amount of blood that's coming back to the heart, the more our heart muscles will stretch. And so we will go from less than optimal closer to optimal. So as the preload increases, our heart muscles stretch and our sarcomeres will automatically produce more force. So this is essentially the Frank-Starling mechanism. So the more blood we have returning to the heart, the greater the venous return, the greater the preload, automatically our heart will increase contractility. So let's take a look at left-sided heart failure. So here again is normal blood flow. So we have blood from the body going to the right side of the heart, then sending it to the lungs, sending it back to the left side of the heart, out to the body. When the left side of the heart fails, this box is not working. And so the body is getting less blood, and blood is getting backed up in the lungs. So we'll start to see the consequences of both of these. So we'll start to see fluid building up in the lungs, frothy sputum, and then the body will start to get obviously less blood and less oxygen. In right-sided heart failure, it's this box, the right side of the heart, that's not working properly. So it's not receiving enough blood from the body, and so the blood will back up in the body. We'll start to see congestion in the body. And the right side of the heart is not sending enough blood to the lungs, so we'll have less oxygenated blood. So this is another figure that kind of indicates this. So let's start with right-sided heart failure. So when the right side of the heart fails, we have blood getting pooled in our peripheral tissue. So we get congestion in our peripheral tissue. So we'll see things like edema, ascites, congestion in the liver, the GI tract, etc. When the left side of the heart fails, we are not sending blood out to the body like we should, so we have decreased tissue perfusion. So our tissues are not getting blood. We'll also see blood backed up in our lungs, so we'll see the consequences of that, so pulmonary congestion. So that will impair gas exchange, leading to cyanosis and signs of hypoxia. We'll also see the fluid buildup there, so pulmonary edema. So we'll see the cough, the frothy sputum, etc. So pulmonary edema, fluid in our lungs. Why is it so bad? So when capillary fluid starts to move into the alveoli, as blood gets backed up, our lungs become stiffer. So our lungs, when we breathe, they expand, the alveoli expand to fill up with oxygen, and then our lungs recoil to exhale. So when we have fluid in the lungs are stiffer, and so it's not going to expand like it normally should, so it becomes harder to inhale. Also, that fluid will increase the diffusion distance between our capillaries and alveoli, so there's going to be less gas exchange, plus the fact that we're getting less oxygen in as well. And then all that fluid leads to crackling sounds when we breathe, frothy sputum, and as a result, our blood, the hemoglobin in our red blood cells, will not be completely oxygenated. So, Mr. Max has heart failure, and he complains of severe shortness of breath. He has fluid in his lungs. He has tachycardia, increased heart rate, increased diastolic blood pressure. He has pale, moist skin, and he says he feels weak, dizzy, and anxious all the time. So which signs and symptoms are caused by decreased renal blood flow? So renal blood flow would be low blood going to your kidneys. So when you have low blood going to your kidneys, what we're going to see is an increase in diastolic pressure. So if you recall, when we have low blood going to the kidneys, this is one of the things that can turn on the release or stimulate the release of renin. And if you recall renin, the RAA, it will increase fluid reabsorption in the kidneys, increasing our blood pressure. Okay, so which are caused by the sympathetic nervous system. So he has heart failure. That's an emergency. We're going to turn on the GIS. We're going to turn on the sympathetic, and we know the sympathetic causes things like increased heart rate, pale, moist skin as we vasoconstrict blood vessels, and anxiety, that feeling of doom. Which side of the heart do you think is failing? And if you take a look at his symptoms, one of the easiest things to look at is the fluid in his lungs. So we know that the lungs are getting congested, and the lungs send blood to the left side of the heart. So the left side of the heart isn't receiving blood like it should, so it tells us the left side is failing. So blood is getting backed up in our lungs. So weakness, dizziness, fluid in the lungs, shortness of breath, all indicate there's too much blood in the lungs and too little going to the body. So how do we treat heart failure? Well, the best thing to do is try to relieve symptoms. You want to improve the quality of life of the individual. And as a long-term goal, we want to try to halt, stop, or reverse whatever is causing the dysfunction of the heart. So it's really aimed at trying to improve cardiac output while minimizing the congestive symptoms and the overworking of the heart. Surgical repair may be required depending on the issue, or pharmacologic treatments. So things that affect preload. So preload, again, is really about how much blood is coming back to the heart. So things like ACE inhibitors might help. So ACE is our angiotensin converting enzyme that's part of the RAA. So we can try to inhibit ACE, which will decrease blood volume. Diuretics will increase urine output and decrease blood volume. And notice these two things will really impact preload. We can also try to impact afterload. So afterload is really talking about the resistance in the blood vessel, so resistance in the systemic circulation. So if we gave a beta-adrenergic blocking agent, we're talking about the sympathetic nervous system here. We're going to block it, so that'll cause vasoconstriction. So it'll decrease our afterload, so our heart doesn't have to work as hard to try to pump blood out to the body. And we can also try to impact contractility. So digitalis is a drug that actually increases contractility to try to increase cardiac output. We can also restrict salt intake, and that will help with blood volume. Diuretic therapy, restrict activity. If you have heart failure, you don't want to start, training for a marathon. And then pacemakers may also be used to help synchronize contractions if required. And that is it for this chapter.